must say that I'm so pleased and proud to be with these young people. They've really impressed me. They've worked very hard. They've been conducting research on different aspects of the spread of malaria in Zambia and efforts to eradicate the disease. So without further ado, they are Lexi Williams, who will discuss lessons learned from the fight against HIV/AIDS in Zambia for those seeking to eradicate malaria. Halim Labi, who will contend that civil society should be more fully engaged in decision-making about policies to eradicate the disease. And last but not least, Caroline Gurek, who will explore the role of women in Zambia's quest to eradicate malaria. So I will turn the floor over to Lexi, is our first presenter.
Good afternoon, everyone. My name is Lexi Williams, and I am a junior at the University of the South. Today, I invite you to come along with me as we explore the question, is HIV/AIDS the solution to malaria eradication in Zambia? HIV/AIDS and malaria are both labeled as diseases of poverty, disproportionately affecting those living in poverty and exacerbating social inequities. HIV is the leading cause of death in Zambia. Similarly, HIV and malaria are both some of the leading causes of death in children younger than 5, accounting for 9.6% and 7.9% respectively. They also share a high comorbidity. Zambia's battle against HIV and AIDS has been long fought, with both highs and lows, lending it to be a wonderful beacon to learn from as we move forward with malaria eradication. HIV/AIDS advocacy in Zambia has been effective in promoting social change by headlining familiar advocates, using strong domestic actors, and locally relevant frames. One of the most prevalent advocacy networks in Zambia are faith-based organizations. CHAZ, the Church's Health Association of Zambia, accounts for 30% of healthcare there, emphasizing not only their financial capacity, but also the social and political soft power they have as advocates. Advocacy for HIV/AIDS has also been successful by using the human rights and evidence-based medicine frame, enabling them to clearly communicate and register salience amongst the communities. There has been a shift regarding voluntary responses, especially HIV testing and women seeking counseling. HIV/AIDS advocates have faced the challenge of different theologies and approaches being used by different advocacy groups, which emphasizes the need for communication between various networks and sectors, especially regarding educational programs. One of the most important lessons to be learned from HIV/AIDS in Zambia is the usefulness and efficiency of public education programs. In Zambia, the big 3 platforms used to share information about prevention were churches, radio stations, and commercials that involved high-profile people, ranging from celebrities to former presidents. Churches offer an untapped potential for sharing information as a result of their respected status in the majority Christian state, as well as how they are guaranteed an audience. Localized, or better yet, contextualized radio programs are highly effective as they are able to account for language barriers, local literacy rates, and also approach controversial parts of society through contextualized lenses. Radio programs also provide widespread access to important information, reaching well into rural Zambia. They also provide opportunities for community engagement in environments where multiple people can listen together. Commercials showcase the capacity to be highly effective, especially through the use of high-profile citizens by shifting norms and challenging social taboo. The most common element that these platforms shared was their focus on prevention, specifically the use of condoms, medical male circumcision, and the use of vaginal microbicides. In an environment where malaria can claim a life within 24 hours of the first display of symptoms, educating and providing consistent resources for prevention is paramount. Health infrastructure in Zambia still faces many of the struggles it did during the beginning of the AIDS epidemic, especially for rural citizens, which accounts for the majority of the Zambian population. Efficient steps that were introduced for HIV/AIDS were home-based care and strain and treat practices. These localized addition to healthcare infrastructure helped to mitigate the strain placed on rural citizens as a result of inaccessible healthcare, and also increase the speed and efficiency that patients are able to receive treatment. With a disease like malaria, local and fast treating options are not only necessary, but they also promote community engagement and care. Specifically, regarding policy implementation, one of the best moves that Zambia made in the midst of their battle against HIV/AIDS was the provision of free antiretroviral treatment. This was a great step in the right direction, yet it failed to incorporate support for people who lacked the resources to adhere to treatment to make it successful, such as a balanced diet. Free provision of fixes is a step in the right direction, but it is imperative to provide resources that are sustainable and lend themselves to be as efficient as possible as they are provided. Some lessons we can learn from Zambia's approach with HIV/AIDS include the ways that the church as an institution and faith-based organizations offer a phenomenal platform to encourage social change and afford community support as a result of their coveted social status. We learn the importance of accessible educational programs that account for literacy rates, local languages, and simply access to receive it. We learn of the value of home-based care and screen and treat practices as localized healthcare infrastructure. Most importantly, from the HIV/AIDS epidemic, we learned that a holistic approach is essential in order to create a sustainable eradication program. We must account for the systems in place that challenge effective eradication, addressing challenges posed in every sector, not just healthcare. This is the end of my formal presentation. I sincerely appreciate your time and attention, and I would like to now turn your attention to my friend and colleague, Halim Labi.
Top-down decision-making in the role of civil society in Zambia by myself, Halim Labi, class of 23 at Swan. Malaria is a disease that originates from a parasite located in certain mosquitoes. Transmission occurs when the people encounter the disease-infested insects and are bitten. Symptoms can mimic the flu while including shaking chills. 90% of malaria cases occur in sub-Saharan Africa. This is a result of the World Health Organization's top-down decision-making. Top-down decision-making means that governmental entities, massive organizations, or elite and executive bodies make the policies and priorities that other organizations have to follow. The WHO was the elite decision-making body that pushed for the global malaria eradication program that focused its vast amount of efforts and resources around the world, except for sub-Saharan Africa. Today, the WHO is still the major decision-making body, pushing for an anti-malaria initiative called Rollback Malaria Initiative. While Rollback Malaria is a definitively more versatile and competent program relative to its predecessor, the Global Malaria Eradication Program, there is still an opportunity to allow for greater space of communities and individuals most impacted by malaria to play a more active role in policy towards dealing with malaria. The way to do this is to involve civil society, which we will define as neither the state, nor the market, nor the family. The World Health Organization's 1955 Global Malaria Eradication Program was a failure. Through an insecticide called DDT, malaria was wiped out from the US and an array of European countries. While these countries experienced success with DDT, eradication of malaria became the #1 priority of all measures to combat the disease for the next few decades to follow. That meant a reduction of investment towards resources and strategies that centered around control and prevention of malaria. This happened because of a few reasons. The decision makers pushing for malaria within the WHO were either state or individual donors. Donors are always looking for programs that will yield the greatest returns in production relative to the financial investment they put in. Eradication provided donors an easy fix solution where investment could stop as soon as the program was successful in a global removal of malaria. Control efforts implied a much more dubious process with continued investment for ongoing efforts to mitigate global malaria. This short-sightedness led to a push of a much more dubious process. The problem is not that the donors were so short-sighted, but that they were the only voices in the room and therefore lacked the perspective to see past their short-sighted efforts. Lacking perspective provided for an inflexible program that failed to properly deal with malaria. The World Health Organization's Rollback Malaria Initiative is more flexible than the Global Malaria Eradication Program. Between the period following the Global Malaria Eradication Program, which ended in 1969, the world simply lost interest in combating malaria. It was during this period where the disease made its biggest spreads within the majority of sub-Saharan African countries. This resulted in African scientists calling upon their political leaders to bring about the 1997 Multilateral Initiative. Here, African leaders could call out the Western world and its top organizations for their choice to neglect dealing with malaria. It was a choice because choosing to deal with disease like river blindness, which had been affecting the English for 2 to 3 decades, they solved the issue. Why, asked the African leaders, should malaria be any different? Their question is what sparked the call for a rebirth of a global commitment to dealing with malaria, which resulted in the 1998 Rollback Malaria Initiative. Learning from mistakes of the past, Rollback Malaria was significantly more multifaceted. It accounted for early malaria detection, rapid treatment for those who are ill, multiple prevention strategies, and more. No longer would malaria be a one-size-fits-all issue with eradication as the sole solution. Notice that the key differences between the Global Malaria Eradication Program and Rollback Malaria have everything to do with the decision makers. The Rollback Malaria Initiative had the privilege of being put into construction from the voices of people most affected by the issue at hand, the African scientists and leaders. Why not business and why not the state? The private sector provides versatile and important innovations that aid in dealing with malaria. The problem is that these innovations often don't have an equitable output. Resources provided by business often best aid those that can best afford them. So sub-Saharan Africa's most vulnerable often won't be able to benefit. Politicians and other facets of the state could push for what is politically expedient. Working with the state is imperative to serving its people, but there are obstructions between the interest of communities and the people that represent them. Civil society and civil society organizations are some of the best ways to really hear the concerns and priorities of target communities. Organizations like a local church or another community-based focus group allows for intimacy, empowerment, and ownership. The World Health Organization should open the floor for civil society input in their policy advisory committee because this is the most optimal space to do so. I am now going to share the floor with my friend and colleague, Caroline Gurek.
Hello, everyone. My name is Caroline Gurek, and I'm a rising senior at the University of the South. And this summer, I had the opportunity to research malaria as a women's issue. Let's jump into this topic of endurance and empowerment in Zambia. Diseases like malaria often amplify inequalities within a society. And so while malaria undermines Zambia's development, Zambian women suffer disproportionately. Today, I will discuss 4 major topics. First, how malaria has sabotaged the economic prosperity of Zambian women. Second, how the country would not only benefit from the eradication of malaria, but also the empowerment of its women. Third, how women in Zambia have gone above and beyond in the effort to treat and fight malaria in their communities. And finally, how to pursue the eradication of malaria with women in the forefront of this issue. Zambia is a patriarchal society, so women customarily work within the household and invest more time and resources towards their children. Within Zambia, women are the primary caretakers of those infected with malaria. Because of this, women are forced to forego career growth in exchange for caretaking. This becomes very obvious when we compare agricultural efficiency between male and female farmers and employment. You can see here that the average harvest per hectare in Zambia, men produce more of almost every crop. And this is the status of employment among those working in agriculture, fishing, and forestry, and it shows that a majority of men are self-employed while a majority of women are unpaid family workers. And as you can see, through the estimated earnings of men and women, men make significantly more. There are many benefits to the eradication of malaria, and while saving lives is by far the most important, here are a few others to consider. The healthcare system, first things first, eradicating malaria would help stimulate the process of development. The healthcare system would be less stressed and more available. Trade would increase as fear of contagion decreases. The workforce would become more productive because caretakers and those ill would be able to work and grow in their careers. Development also spurs gender equality, which leads to female empowerment. It is understood that economically empowered women invest more in their children's education, food, and health services. Women have been fighting and treating malaria for a long time. 80% of malaria cases in young children are treated by women. There's currently an all-women lab collecting high-quality data on malaria run by the Malaria Control and Elimination Partnership. This program is sponsored by PATH. They are known as the backbone of the Zambian government's data collecting necessity. Scientists like Mulenge Mwenda Chimfwembe grew up infected with malaria and saw how her mother would have to miss work in order to bring her to the doctor. She now works in a lab fighting malaria and mentors other young women. It is good to know that the number of Zambian female doctors is rising. Now that we have recognized malaria as a women's issue, let's talk about policies that place women in the forefront of this. Investing in clean water and sanitation is extremely important. This can help individuals recovering from malaria, and it has been proven to decrease deaths among young girls. Formal and informal surveillance of malaria is essential to accurate data and informing individuals about contagion. Formal surveillance includes labs and data collection, like the Malaria Control and Elimination Partnership. Programs like this promote eradication of malaria, but also career growth for females working for them. Informal surveillance could include blogs, online discussion forums, and eyewitness reports within media reports. Women could use informal surveillance as a way to share their experiences as caretakers and the losses they have suffered caused by malaria. Giving women outlets to use their voice empowers them to share their struggle and involvement and inspires others to do the same. Education has the ability to be the great equalizer of the world. Educated women are more likely to have healthy and educated children. More educated women means more women doctors, scientists, and government leaders. Education allows women to be more knowledgeable about the symptoms, prevention, and treatment of malaria. As the name suggests, Malaria Partners International have quite a few partners helping them reach their goal of malaria eradication, a few of them being PATH and the Bill and Melinda Gates Foundation. So I wanted to draw your attention to more potential partners. CARE is an international nonprofit organization that currently has a program in Zambia. They are focused on female empowerment and health. The Safe Motherhood Alliance is a Zambian organization that helps women in rural areas have safe births. They deliver birthing kits to mothers who may not have access to healthcare services. And finally, the Zambia Alliance of Women is a non-governmental, nonpartisan, nonprofit organization that focuses on gender equality and sustainable agriculture. It is time to bring women into the discussion of malaria eradication. As mentioned before, diseases like malaria often amplify inequalities within a society. Effective policies and initiatives will seek to counteract those inequalities in pursuit of the larger issue. Here is a QR code you can scan with your smartphone, and it will take you to a summary and full version of my report. Us presenters will also be available after the meeting to answer any questions y'all have. On behalf of Lexi, Halim, and myself, I would like to thank you all for giving us this opportunity to share what we have worked so passionately on for the past few months. And we hope that everyone stays safe and healthy, and we'll hopefully see you all again very soon.
Okay, well, I want to thank Lexi, Halim, and Caroline for the presentations. If there are any questions, would you just unmute yourself?
Hey, Bill, I have one, if you don't mind.
Please, Dr. Sand.
Yeah, to the three of you, very well done. Excellent reports. Holly, welcome. And thank you for the fine mentorship you're giving to them. Looking at each of your three reports, going to best practices, what would be one each that you've identified as far as how we can address malaria, which in essence is killing about a child on the African continent about every 30 seconds under the age of 5. So that's a huge loss of human talent. So if you wouldn't mind sharing best practices, that's what we're all about. And thank you for being here and sharing. And Shelley, thank you for allowing us to be part of this.
So, Caroline, would you like to unmute yourself?
Yeah.
Maybe you could speak.
I think a common theme that may run through all of our projects is that initiatives that are community-based allow for the most agency among those local individuals. So I would say that community-based initiatives are probably the most important.
So initiatives should be community-based. How do you make an initiative?
I can definitely contribute next because I know I focused a lot on
You're
bringing up civil society. The reason why I didn't have specific examples of civil society organizations is because I don't think we should come up with ideas of who to involve off of who I looked up on Google. I know within my community, a big civil society organization is the church. It's a place where you can be intimate with other people. You can feel empowered in Sunday sessions, and you can have ownership on the decisions in which the church is going to go through to elevate the community. And I think organizations can find out the impact that the church has based off of their locality and based off of how connected they are to that community. And I don't think researching from a distance is a way to be able to connect to those types of organizations and communities. It takes on the ground connection. It takes going out of your way to talk to people. It takes, okay, if we want to work with this civil society organization, let's find the people that attend there. How do you feel about that? How is your voice empowered within that space? How do you think that they represent your values? And how do you feel about us moving them in within like the World Health Organization as like a decision maker for policies? I think a more hands-on approach is necessary to finding out these things rather than a hands-off and far away distance.
Dr. Sam, thank you for that question. Kind of going off of what Caroline was saying, I would really like to emphasize the importance of community-based and especially localized healthcare, especially within that screen and treat practices, because of how quickly malaria becomes fatal within the presentation of those first symptoms. Being able to diagnose it for what it is and get those people treatment is one of the most important things. So having community citizens that are able to help each other, I think is one of the best practices that can be implemented.
Okay. All right. Do we have another question from someone?
Yes, I have a question.
Yes, go ahead.
Since it's been known for over 200 years that the cause of malaria is the infection of the parasite carried by the mosquitoes in Africa and Asia, what are you doing to encourage the sterility of these mosquitoes, or taking the alternative of using certain techniques to kill them so that malaria can be eradicated and save communities lots of money by not having malaria? So are you looking into this issue? Thanks.
Yeah,
I'm going to start with Caroline.
unfortunately, none of our research really covers that, but I was told by Dr. Shelley that Dr. Sam may actually have an answer to this question, a far more accurate one.
Well, I didn't know I was going to be put on the spot, but
Sorry about that.
Anything that Dennis wants to know about. Dennis, there's the movement to sterilize the male mosquitoes so they're not breeding in the wild is actually going on in some experimental projects. I don't know of any that's extensive or nationwide, but it's something that they're looking for as a very promising opportunity to eliminate the fertile mosquitoes that generate thousands of progeny, and then also there's some other technologies that can be used for this. I know the Gates Foundation is actually working on a vaccine, and they've spent probably almost up to $1 billion on that.
Thank you, Dr. Sam. So, yeah, that's the traditional approach has been to try to do something about the mosquito population. And of course, the bed nets have been very effective in many places. Did any of the three of you look at these, shall we say, control methods to avoid infection, like the bed nets? Bed nets seem to be the most widely used.
This is Marinelli. I'm driving to go meet the students. But I just wanted to comment on the best practices. Is the work of community health workers.
Right.
Detecting. Early detection is very important, because at the end of the game is reducing child and maternal mortality due to malaria. So that will be one aspect. And of course, it's community-based also approach to using the support of community health workers trained by experts. And we can say the Rotarians are helping on this. I belong to the organization Malaria Partners International, who also support these studies and the work that the three students have presented. and I just cannot say enough of how wonderful was this presentation with their different approaches, different angles, very creative angles on how to address this problem beyond what we already have been discussing. So I just want to congratulate you, and I hope to see you soon.
I also want to be able to address what was said about the insecticide nets. I think the research and the data on the preventative measures are solid, but I think that does nothing unless communities buy into them themselves. So an insecticide net does nothing if a mother's not willing to use it to protect her child from malaria or her unborn child. And oftentimes she herself is not going to understand the science and the data behind that. So there has to be faith in the institutions that provide these types of information and resources, which is why I think a good way to go about cultivating that faith is to allow her to have ownership in the decision-making process. So not only does she get a net, but then she talks to all her friends to getting a net, and these informal sectors spread about in areas that we wouldn't even think to look after because they're not easy to see.
Thank you, thank you. No, I want to congratulate our young researchers. This is wonderful, and you are absolutely on target. At the Rotary Club of Washington, D.C., we are now within the International Service Committee. We are engaged right now in the process of a community assessment in the Democratic Republic of the Congo on malaria. Not only eradication, but the whole picture. And we are finding out as the community assessment is progressing, is that what is being found on the ground is exactly what you're talking about.
So I thank you. And this has really been great. And it's such an important topic. And, you know, everything we're trying to do is involve youth. And I admire the work you do, Shelley. And
Hala was the mastermind behind a lot of this. The students did the hard work, and she directed the research, and she's an Osgood board member of whom we're very proud.
Absolutely. And we want to see more of it and keep us posted, because we have this youth focus. And that's what you've been doing, Shelley, for quite some time.
That's what we do. That's what we do. Thank you so much. I appreciate it, Bill. Thanks for the opportunity.